Which brings me to the use of Diamox. If you work in the medical ICU and you're using Diamox more than once a month, you are abusing Diamox. That's too much. Some people just keep using it without thinking about it. And by the way, that's also propagated by what? The nurse is supposed to give you all the critical values. So she will run to you, or he will run to you with a paper that says CO2 greater than 40, which is bicarb greater than 40. And you feel like you have to do something about it, so you give Diamox, and that's the wrong thing to do. So can I tell you, and you tell me, I ask you, 7.4, 60 PCO2, bicarb 30, and 7.4, 90 bicarb of 45. Which gas is better?
The first one was better.
Why?
It's closer to baseline.
That's a good question. That's a good answer. Yes, it is closer to baseline, but that's not the physiologic answer. What do you mean? I can argue. There's some idiots that argue that 90 is better for ARDS patients. Have you heard that permissive hypercapnia bullshit? Permissive hypercapnia. Let the ARDS patient accumulate more CO2 because it dilates the blood vessels. All this bullshit. It's the pH, not the PCO2. But anyway, that's not the reason. That it's close to the baseline. So okay, closer to the baseline, give you what? Like these two people, we agree that they're as awake as each other. They're not sleepy. Because it's the pH that affects it, not the PCO2. And both of them, we agree that they're chronic. They're not happening today, both of them. Huh? Which one is better? Of course this one is better, but for a different reason that I didn't write on the board. It's the alveolar equation. You know the alveolar equation? That detects how much oxygen in the alveoli? So P alveolar O2 equal what? P inspired O2 minus PaCO2 divided by the respiratory quotient. Please don't memorize things. Just think about it so you can make it up as you go. This is basically saying whatever oxygen in the alveoli, to calculate that, just see how much oxygen is going in minus what's the occupant of the alveoli at end exhalation is PCO2. Forget about the respiratory quotient. That's depending on what you eat. I think that this is prejudice against me. But anyway, so the higher the PCO2, the lower your alveolar O2. So that's why, although these two people are, from the ventilation point of view, they're equal, they're awake, this one is going to potentially have a lower PO2, right? Because the P alveolar O2 is going to be lower. So the chances of this guy becoming hypoxic is much higher than this guy becoming hypoxic. So one smart pulmonologist one day came up with this idea. He said, okay, well, we can correct that. So I have a chronic COPD here that actually lives at 2-liter nasal cannula, and he's coming today complaining that he is having, he's on 4-liter nasal cannula, right? He just increased it at home because he's hypoxic, he has a pulse oximeter, right? So what am I gonna do? I'm gonna give Diamox. Diamox is a weak diuretic that gets rid of the bicarb, and when it gets rid of the bicarb, sodium follows, and then water follows, and weak diuresis, but at least gets rid of the bicarb. If I can get rid of this bicarb a little bit, so I have now the PO2, for example, is 50, okay? If I can get rid of the bicarb, make this 40, for example, the pH is gonna be a little bit on the lower side, okay? So he wants to breathe a little bit to normalize it, so we make this 80. Bring this back to 7.4. So I forced him now to bring down his PCO2. By dropping the bicarb, I forced him to breathe a little bit faster, bring down his PCO2 to 80, and that gives me more chance of increasing the oxygen. You know, the oxygenation will improve because the PCO2 is lower. So I give him more Diamox until as much as he can tolerate. But you have to have 4 conditions that are all have to be available in the patient that you're giving Diamox to. Otherwise, you're killing the patient. So number 1, the patient has to be hypoxic. Otherwise, if he's not hypoxic, why doing it? We said that. So you're not giving it for the number, you're giving it because the patient is hypoxic, you want to treat this condition. Number 2, he's also having a very high bicarb, like the bicarb is above 35. Right? If it's below 35, don't try to bring it down. You know, that's not the reason he's hypoxic. And then number 3, the patient respiratory rate is less than 20. You can't do it for somebody who's breathing at 30. You're gonna make him fail. You're gonna make him get intubated. And then number 4, the pH has to be more than 7.35. If the patient is less than 7.35, then he's acidotic. You give him something to make him more acidotic, then you basically worsening the patient.
How does like apply for the use of Diamox for like altitude sickness and like not like?
Oh, the altitude sickness use of Diamox is similar to that. So basically what they do is that, yes, you're very, very hypoxic because your whole barometric pressure is low and the PO2 is low. So what you're doing, the only thing that you can do to help yourself is to bring down your bicarb so your body starts to breathe a little bit faster. So you're actually running at a PCO2 of 25 or something, right? And allowing more chance to have more oxygen in your alveoli that way. You know, so that's altitude sickness. At least one mechanism of Diamox working in altitude sickness. Well, that brings me to some controversial stuff on the vent. I'll tell you what the controversy degree. I end all my lectures with controversy at the end, or potential for study. So there's one that is really like grade 2 controversy, and the other one is grade 10 controversy. You gotta kill me when I tell you the other one. But both of those that I'm telling you about, and I stand by what I'm saying. No intensivist is doing it that I know, at least. No intensivist is doing what I'm telling you. What I'm telling you here. Maybe some of them do it shyly, every once in a while, but it's not their practice to do it. So let's say Mr. X, who is a bad COPDer, who lives, as we agreed, 7.4, 70, for example, and a bicarb of 4. Okay? So now he's on the vent. And there's many reasons for this to happen. He's developing a little bit of acute renal failure, or we're giving him a lot of normal saline, and his bicarb is drifting down. Or, more commonly, by the way, the stupid idiot who's ventilating him is trying to ventilate him to a normal PCO2, so he doesn't like that, so he keeps on bringing down to the PCO2 to 55, for example, and this one goes to 7.5, right? And a bicarb 40. So what do you think the kidney is going to do? Over time, if you continue like this, over time the kidney is going to do what? It's going to bring this down. It's going to say, okay, we're going to lose some bicarb because we're alkalotic here. So over a day or two, it's going to say, okay, bicarb now is 28. 55, 7.4. So the kidney now normalized the action here, right? Now, this guy is 28 now, which is a higher bicarb than normal. But it's not his normal. So every time you take this guy and put him on SBT, he fails. Because he has pneumonia, he has COVID, he has ARDS, he has all of these things. On top of his bad baseline. So at baseline, he would love to be in the 40s PCO2, but he can't. So he's doing 70 PCO2, and his kidney's trying to be like the crutch, giving him 40 bicarb. Now we took that crutch away, right? Now he has to be what? He has to be 40. Or 45 to achieve, 55 to achieve a normal pH, right? But he runs at 70. So do whatever SBT you want to do. It's not going to happen. At baseline, he can't do it. So now with the pneumonia that he's having in the ICU and the fluid that you're giving him and the pleural effusion and the COVID and all of these things, he's going to be normal. He's not going to be. He's going to fail every single time. And that's why tons of people fail the vent, and people's like, oh, I don't know, let's take him. Just simple. Increase his bicarb, make the bicarb 40, and then this way he doesn't have to bring his PCO2 down to 55, it'll be PCO2 of 70 and 7.4. Here, he had to breathe at 40 respiratory rate to achieve this. Here, he can breathe at 28. And here he can be extubated, here he cannot be extubated. Right? So that's very simple. We agree on that? But you agree on it, but you're not looking for it. From now on, you're gonna be looking for this, and you're gonna detect it, right? You're gonna say, this guy, yes, I know his PCO2 is I know his bicarb is 30, but he runs at 45. Let's make him 45, right? The way we do it is different. We can do it with PO bicarb, we can do it IV bicarb, we can do it THAM. THAM is better, but we'll talk about that in another time. So let me tell you about the other controversy that's actually, I could be stoned for this actually. I could be stoned. So, and it happens a lot in the trauma ICU, by the way. And that's why trauma ICU, one of the reasons, trauma ICU has a lot of trachs. Of course, there's legitimate trachs, going back to the OR a million times. Of course, you do a trach. But there's sometimes illegitimate, right? So let's say Mr. X is having, so basically, we'll talk about lung score for injury. There's not a lot of universal lung score, injury score for the lung, that everybody agrees on, right? So I'm gonna make my own score. I'm gonna call it the shittiness score. It applies to all lung disease. It doesn't matter what your lung disease is. Is that what's your PCO2 ability to change PCO2? What's your ability to change oxygen? And we give you a score from 0 to 10. It's called the lung shittiness score, LSS, okay? or we do the Surur lung shittiness score, we call it the triple S. So that's that. So Mr. X, who's been a COPDer for all his life, his ability to change PCO2 and oxygen is very low, so his lung shittiness score is 8 out of 10. It's really bad. It's one of the worst. He's a terminal, right? His pH is what, 7.4, 70, 40. Okay? And then Surur had a car accident. I have a normal pH. I run normally at 7.4, 40, 24. Okay? Had a car accident. My lung is fine. It's just my pelvis is shattered. So then I developed ARDS. So I was normal today. I had the car accident. Tomorrow I'm in ARDS, and my lung shittiness score is 8 out of 10. Right? I became as shitty as the other guy. This guy spent 40 years to become that shitty. I spent 1 day to become that shitty. Right? What's the difference? He had all the time in the world to raise his bicarb. I didn't. I didn't have the chance. So what happened in those ICUs is that the intensivists try to do what? Well, 7.4, 40, 24, beautiful. Let's put him on an SBT. He's breathing in the 50s. Oh, okay, his ARD is getting the worst out of him. Okay, let's try again. Next day. Oh, you can't. Let's trick him. Whereas, very easy. We've done it on tons of COVID patients when they were here. Tons. In fact, that was the most commonly used medication on COVID patient that we used in this epidemic. How about if we take this artificially? I've never seen a bicarb of 40 before, never. But I'm now as shitty as this guy. So raise my bicarb to 40. Of course, adjust the vent accordingly. Let me decide. Don't let the vent. Don't decide for me. Don't be breathing for me. I'll breathe. Reduce the respiratory rate. Let me breathe whatever I want. I probably gonna, slow down my breathing because I don't need to breathe that fast, and achieve a PCO2 of 65 or something, and pH of 7.4. So I went from here to here. Stayed the same pH, but respiratory rate, instead of respiratory rate of 50, respiratory rate of 30. Much more manageable and potentially extubatable than this, just because I raised this. You know what I mean? Of course, there's other confounding factors. If my lung is so injured that I'm hypoxic, I'm not going to be extubated anyway. But I'm talking about, if you have an isolated, or at least majority, or at least you want to get rid of that, then please raise the bicarb, simulate what happened to Mr. X, right? Make me not. Don't they say? Don't they say? We do that in all other organs, but not this one. For pancreas, for example, just rest the bowel a little bit, have him so it doesn't show up. Somebody who's bowel obstruction, rest the bowel, it's gonna move and move, whatever. Same thing for the ARDS as a concept, don't bang on the lung, just like don't let the, just permissive hypercapnia, let the, accept lower pH, accept lower PCO, even oxygenation, to just, because the lung, although it's the organ that gives us the oxygen and the CO2, it is also can be severely injured if you actually bang on it with the vent. Same idea. Give me bicarb so I don't have to breathe that fast. So let me be. And this way I can easily be extubated. if you tell that to anybody, they're probably gonna stone you. They're gonna just like say, you're fired. You're not gonna even finish your residency here, because it's so difficult to understand why am I raising the bicarb to 40. Couple of things you're gonna hear, just so we'll be complete on this point. You're gonna hear people saying, "But you're an idiot. You're giving bicarb, and the bicarb is raising what? Both bicarb and PCO2. Sometimes when you have acidosis, you take the hydrogen ion, and the bicarb becomes CO2 and water. So you, at some point, if you give so much bicarb, the bicarb is gonna rise, and the PCO2 is gonna rise. So this is gonna rise too, and it's gonna be a problem. You're gonna be acidotic, or you're gonna have to breathe fast to come out to compensate for the PCO2 or something like that. That's not true, especially on a vent. It is true that the PCO2 rises a little bit with bicarb, but you can combat this with a little bit of hyperventilation. You can do it for the patient for the first hour or two. You give bicarb, you ventilate the patient, PCO2 comes out. Few breaths, PCO2 that comes out of the bicarb will come out, and then you'll settle at a lower respiratory rate. The other thing that will also make it a little bit complicated is the patient will be breathing fast for a different reason. So even though you left the patient to his own breathing, you're not iatrogenically over breathing the patient, he's not going to achieve CO2. Why? Because he's anxious, he's having pain, he's hepatic encephalopathy, he's hypoxic, severely hypoxic. So then he's going to be breathing this like 50, this is 40, and the pH is 7.5. Right? So if he continues to do that, all the bicarb that you'll be giving to the patient will be dumped in the kidney. It'll be dumped in the kidney. Because the kidney is going to say, okay, I'm getting bicarb, but it's alkalotic, which is going to lose the bicarb. So it's going to be useless. Right? So do whatever you need to do. Maybe sedate the patient, do whatever. Sometimes you can't do anything. Sometimes just the patient is breathing fast, you can't do anything about it. But many times you can easily resolve that by just sedating the patient a little bit more or something like that. And of course, the PCO2 problem with giving bicarb is resolved by SAM, which we'll talk about it another time. All right, that's it, professors. Any questions? There must be a question, no? All right, very good. All right.